Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues in PGs, we are discussing the challenges in the management of a decompensated liver patient. In the first part, we discussed that when we will call a patient to be having a decompensated liver cirrhosis, and then in the second part, we discussed the components of the management of such decompensated patients. In this part, we shall find out what are the challenges in managing decompensated liver cirrhotic patients and what are the ways and how to overcome these challenges. So, in this part, we are going to find out what are the challenges in our day-to-day clinical practice and how to overcome these challenges in the management of decompensated liver patient. This is the case history I have shared with you. I've discussed with you in the first two components. I don't go into the detail of that. You already know this. If you haven't, then please go and watch my first and second videos on the topic. The links is present in this description. So in this patient, if you concentrate, the patient 13 years ago, he was found to be anti-HCV positive by ELISA. So 13 years right from today, he was found to be having anti-HCV positive, and he goes to his doctor whenever problem arises for his diabetes and hypertension. And now when he presented with moderate ascites in space occupying lesion and the 3 columns of moderate large esophageal varices with EG1 was on his endoscopy. So these are the components that know that 13 years ago the patient was found to be having HCV positive, but neither his PCR was checked to see if the patient infection is active or not. Neither he goes to the doctor, well, not very regularly, but whenever problem arises, but he goes to a doctor who is probably mostly concentrated on the blood pressure figures, what is the value of blood pressure, and of course maybe the sugar figures. He has never been worked out properly for his liver status. His first ultrasound at the time of cholecystectomy did show that the patient has got mildly coarse echo pattern of the liver and with mild splenomegaly, but he was never assessed for his liver status. And when he presented with a really severe decompensation, the ascites and hematemesis and melena and the space occupying lesion. Even with his regular follow-ups, his ascites or his tummy was not given care to see if the patient is going to develop ascites or not, and there was no something to find out to look for this surveillance, to do the surveillance for the space occupying lesion. And even no endoscopy was done, and when the patient was scoped, the patient was having advanced portal hypertension and bleeding esophageal and varices along with the gastric varices. So what are the challenges? What are the challenges in the management of our decompensated liver cirrhotic patients? And these challenges, one is the lack of in-time diagnosis of chronic liver disease. You see, this patient was found to be having HCV positive. His liver was having coarse echo pattern with splenomegaly 13 years ago, and he was having comorbid conditions of hypertension, diabetes. Probably he was obese as well, which is not obvious in this history, but probably he was. So his liver status, his chronic liver disease was not properly diagnosed. And it took 13 years when this patient presented to the emergency room as a decompensated with upper GI bleed as well as the moderate ascites and hepatic encephalopathy. Second challenge is the lack of proper monitoring of chronic liver disease patients. These patients used to go to his doctor, and the doctor is probably mainly concerned with the diabetes and hypertension things. and his liver status was not properly monitored. And the time when the patient presented, the patient was having huge ascites, the patient was having upper GI bleed, the patient was in coma, and the patient was having even space occupying lesion. So this is the second challenge. Third challenge is lack of proper prophylactic strategies. If this patient would have diagnosed chronic liver disease, the prophylactic strategies, especially for the venous bleed, must have been initiated by his doctor years ago, and probably this was not have been the status that he presenting with the advanced portal hypertension. Lack of preempting decompensation. This is another very important thing. We mostly miss this. We don't preempt that this decompensation can happen. So this is another challenge in the management of cirrhotic patients in our setup. Then lack of properly trained and dedicated team. This is important, that we haven't been able to train the make the team and dedicated teams for such cases. And of course, there is no lack of MDT strategies. The culture of the MDT is limited only to few centers. By and large, it lacks in our clinical practice. So, the same study, the patient was discharged on diuretics, carvedilol, lactulose, rifaximin, antibiotics, and follow-up visits. Now the patient has been given the diuretics for his ascites, carvedilol, beta blockers for the secondary prophylaxis of the bleed, as well as to have an impact on the ascites, lactulose, rifaximin for his HE, antibiotics for his infection, and of course follow-up visits to see the viruses and other checkups. So, how to overcome these challenges? Let's see how we can overcome these challenges. That is lack of in-time diagnosis, lack of proper monitoring, lack of proper prophylactic strategies, lack of preempting decompensation, lack of properly trained and dedicated team, and lack of MDT strategies. We need to overcome these challenges if we want to ensure that the management of our decompensated cirrhotic patient should be a desirable one. So first, take the lack of in-time diagnosis. We all know that whether this is the viral disease, non-viral disease, and if a cirrhosis has happened with altered anatomy and functions, it's a lifelong disease. We know that it's gradually worsening, a lot of complications, and going to fetal. But for diagnosis, if a patient has decompensation already, these will be the clinical features. It will tell us the patient has got cirrhosis. Like if this patient presented to us with hematemesis and melena, patient may have present with ascites, hepatic encephalopathy, the peripheral stigmata of the chronic liver disease. These are the clinical features which tells us that the patient has got decompensated or the patient has got liver cirrhosis. Forget about the decompensation. Patient has got the liver cirrhosis. The patient may be thinking that the patient has got something like GACE, and when we check them, they have got the ascites. Our ultrasound was done for something else, and the ultrasound told that it's a chronic liver disease with splenomegaly, portal hypertension. Like in this very patient, 13 years ago, he was found to be having a cirrhotic liver, but not a proper timing was attention was given. In the absence of clinical features, this is ultrasound and labs which can tell us the patient has got cirrhosis. Like an ultrasound, it may be small shrunken liver, splenomegaly, portal may not be dilated, ascites may not be there. But it can tell us that yes, this patient has got liver cirrhosis. Labs like low albumin, PTINR prolonged, like the platelet count low, all these are the lab parameters, lab results which can suggest that the patient has got liver cirrhosis. We don't need to do biopsy in such patients. Then, in the absence of the clinical features, with normal ultrasound and even normal labs, then the simple calculators, FIB4, APRI, and if available, FibroScan, these are the parameters which help us to establish the diagnosis of liver cirrhosis. So if a patient is B positive, C positive, the patient is having fatty liver, or if the patient has got other features like the patient got diabetes, please do exclude the diagnosis of liver cirrhosis. Look for clinical features. If they are not there, assess the ultrasound, other labs. If they are normal, please do calculate the FIB4 and APRI, and if possible, do fibroscan to say that if my patient has got cirrhosis or not. This is very, very important. So in-time diagnosis is very important, and we must not forget it. What about the lack of proper monitoring? We make the diagnosis, we have made the patient has got chronic liver disease, but as I told you, the proper monitoring of these patients is not done. It's not that rocket science, it's not that difficult. Just the CTP score and the MELD score, these should be the regular notes, regular parts in the follow-up notes of these patients. Then what is the CTP score, what's the MELD score, because these two scores, they tell us clinically that either if our patient is in the compensated cirrhosis or decompensated cirrhosis, or if the patient is remaining stable. So the CTP score and MEL score, they are very, very important, very, very fundamental. And we all know that on the course of time, the CTP score, MEL score, or MEL plus score are the scores which help us. We know no need to go into the detail. The CTP score, the findings like the encephalopathy, ascites, bilirubin, the albumin and PT, and we divide them into either the child class A, B, C. Child class A is the best one. Child class A is the worst condition. And if the patient is in child class A, the high good survival, 100% of 1 year and 85% of the 2 years, is compared to the child class E, when the survival is reduced to 45% at 1 year and 35% in 2 years. It means we lose most of our patient if our patient is in child class C. And then the MEL score, and it's very not difficult. Just on the smartphone, your phones, you calculate the score and you see whether this what's the MELD score, and depending upon the MELD score, you predict the 3 months mortality. Lower the MELD score, better is the outcome in these patients. We don't do this hepatic venous pressure gradient in clinical practice, but we do know that if our patient is in child class A and low MELD, the HPVG is a less than 12. It is a desirable one. So depend if our patient is in good CTP score, good MELD score, predict that the VPG is clinically insignificant or on the better side. So we have an idea, and we must have an idea of what is the probable HPVG of my patient. So once you diagnose the patient as having chronic liver disease, this is integral component of the management, that the proper monitoring and recording of the CTP score, MELD score is very important, so we know how our patient is going, what's the progress of our patient. Third challenge is lack of proper prophylactic strategies. How we should come about this? We all know that these complications, there are very good primary prophylactic strategies, secondary prophylactic strategies. We should apply the guidelines. Guidelines are there for the primary prophylaxis of the hepatic encephalopathy, variceal bleed, even ascites, the secondary prophylactic strategies, and for the HCC, the surveillance for the HCC. All these are very important, and they should be the essential component of managing these patients. Another challenge is that of lack of preempting of the decompensation, whether my patient can develop a decompensation or not. If the patient can develop a decompensation, when? So we know that the decompensation is the hallmark of the chronic liver disease or cirrhotic patients. They can decompensate as a slow decompensation, or they can go through a fast track requiring the liver transplants. The slow decompensation is not over months, it is over years. 7 years, 8 years, 10 years, even more than that. They decompensate in the absence of the proper treatment. But what is the fast track? What is that fast track decompensation? It is either this is the HCC, the patient developed hepatocellular carcinoma, and now this is the fast track when they will need a liver transplant, or the patient develops acute and chronic liver failure. And again, these are the patients when most of them will need liver transplant. So, key to success is that we should preempt what are the challenges ahead. For that, I will again go to my concept slides, which I shared with you in one of my previous videos, that the chronic liver disease is either the early chronic liver disease or advanced chronic liver disease. Early chronic liver disease means no cirrhosis. Advanced chronic liver disease means patient is cirrhotic. And then the cirrhosis is of has two stages: compensated and decompensated. The first stage of the compensated cirrhosis is when there is no varices, no ascites, and the second stage is when varices appear, but there is no ascites. And in the third stage, that is the decompensated stage, either there is variceal bleed or ascites appears. And this is because of the portal pressure. In the non-cirrhotic patient, there is normal portal pressure, and the cirrhosis it is characterized by the portal hypertension. In the first phase of the compensated cirrhosis, there is insignificant portal hypertension, while in the second phase of the compensated cirrhosis, in decompensated cirrhosis, there is clinically significant portal hypertension. And what are these values? We know that if the HVPG is less than 5 or less than 5, it's a normal pressure, the patient is non-cirrhotic. But when it is more than 6, it is a portal hypertension. From 6 to 10, this is clinically insignificant, and such patients don't have varices or ascites by and large, and this is called stage 1 of the compensated cirrhosis. When the HPVG or the portal pressure rises more than 10, so 11 to 12, this is the stage when the varices appear but ascites may not appear, and this is the second stage of the compensated cirrhosis. And if it is increasing, then it rises more than 12, this is the chance when either the variceal bleed may happen or ascites may appear. So from anything more than 10 is a clinically significant portal hypertension, and then we can further divide this into 11 to 12 and more than 12. We don't need to check the HPVG in each and every patient. APRI can tell us, the FIB4 can tell us, the transit elastography can tell us very beautifully whether the patient has got clinically significant hypertension or not. For example, if the APRI is more than 3.5, if the FIB4 is more than 5.5, or if the elastography is more than 25, it means clinically significant portal hypertension is present. The patient has got the varices, and the patient may develop variceal bleeding or may develop ascites. If the APRI is less than 3.5 but more than 1.6, FIB4 is less than 5.5 and more than 3.6, and elastography between 16 to 25, this is again portal hypertension is present, but it's clinically insignificant, and probably you won't see varices or ascites in such patient. If the APRI is less than 1.5 or FIB4 is less than 3.5 or elastography is less than 15, probably this is the non-cirrhotic stage, and the patient has got normal portal pressure. Though the fibrosis may be there, if you go for the exactly fibrosis when it is 6 to 15 or 1.5 to 3.5 or 0.6 to 1.5, this is a stage when it may be F2 or F3 fibrosis. If it is less than 0.5, less than 1.5, less than 5, this is a stage when there will be F0 of event fibrosis, that we are mainly concerned with this group. And remember that in the non-cirrhotic stage, HCC may or may not happen. In the compensated cirrhosis, HCC does occur, but in decompensated cirrhosis, it's a high-risk group for the HCC to develop. Then, as coming to the HE or hepatic encephalopathy, in the non-cirrhotic patients or in the compensated cirrhotic patients, HE can happen, but this will be as a result of the acute and chronic liver failure. While in the decompensated cirrhosis patient, it appears as a consequence of liver cirrhosis. And another good parameter is platelets. If platelets are more than 150,000, probably it's a non-cirrhotic patient. But if it is less than 150,000, then of course you need to look for all these. So we should preempt and we should see to which group our patient is. If our patient has got clinically significant portal hypertension, patient is prone to develop ascites, develop varices, patient is a high risk for HCC, and patient is high risk for the HE, and the primary and secondary prophylactic measures must be given to these patients. There's a lack of moderately trained and dedicated team. How to overcome that? This is again very important. And how to overcome this challenge? We need to train our team as an indoor. What is the indoor protocols for such patients? What are the outdoor protocols in OPDs? And even we need to train the people, the patient's relatives at the home as well, that what is the home care, what is the outdoor care, and what is the indoor care. We need to adopt the guidelines available for these and train the proper people, proper personnel to take care of these patients at these three levels. So then is the lack of the MDT strategies. As I said, that MDT culture is not very common in our setup. It's limited to only a few centers, but these patients do need MDT approach because they can present with one complications, two complications. We should preempt the coming complication and treat that accordingly. As I said, a lot of people are involved in this team, the physicians, the hepatologists, the endoscopists, nephrologists, sonologists, interventional radiologists, oncologists, cardiologists, pulmonologists, cardiologists, the home nurse. All these are important. All these are important in the MDT approach of these very patients. So this is what I'll share with you, that we presented our data of 2,780 patients in a puzzle 2016 in Tokyo, and out of these 2,780 patients, the 77% of our patients, they are because of HCV, and 22% of our patients, they are because of HBV. And when we see the CTP score, more than half of these patients, they are in child class A, while 36% they are in child class C at the time of presentation, and 11% in child class C. It means that most of our patients, they present with child class A, and if we apply these primary, secondary prophylactic measures, if we do the proper monitoring over time, probably we can affect the we can ensure the good survival in these patients. And the same is with the MELD score. The MELD score less than 10 was in almost half of the patient. So this is a good point, that when a cirrhotic patient presents to us, most of them, or half of them, they are in child class A, and they are having MELD less than 10. And this is a group of patients, when we follow them properly, when we do the primary and secondary prophylactic measures adopt in these patients, probably we can ensure the good survival in these patients. And we did notice that the most common complications at presentation was ascites, followed by the overt hepatic encephalopathy, then coagulopathy, then the variceal bleeding, and all those things. So all these complications do happen, but luckily the HCC and HRS is not that common as the ascites. But it doesn't mean almost 12% of patients they presented with HCC. So again, if the patients are placed in the proper HCC surveillance program, probably we can pick the HCC earlier on and we can handle them accordingly. So to sum up the whole discussion, the cirrhotic patients, it's a very delicate creature. We need to give very special attention to them. This is very, very important, that they need a very special care. Liver cirrhosis has well-defined natural history. A cirrhotic patient must be properly monitored over time. This is very, very important. The decompensation must be preempted, and success lies in the team approach. And never forget to explain the disease and its expected course to patient and relatives. Most of our patients, they don't know what's our problem, what's our survival, what are the issues we should be caring about, and avoid malnutrition in cirrhotic patients. This is a very, very common observation which I have found, that most of our cirrhotic patients, they are malnourished because of the myths and because of the parades and all those things. So thank you very much. I hope in our discussion on the decompensated liver cirrhotic patients, we will be able to find out when we will say that our patient is decompensated, what are the components of the decompensated treatment managements. These are the treating the acute management, then the prophylactic measures, and of course the essential components. And then what are the challenges in managing such patients and how we should overcome these challenges. This is a team approach. Cirrhotics, they deserve to be given a full proper time, proper attention, and they do deserve to be monitored properly over time. And very effective primary and secondary prophylactic measures are available for combating the different complications. And this is our moral responsibility, our professional responsibility, our ethical responsibility, that we implement all these prophylactic measures, proper monitoring, adopting guidelines, developing teams, and helping improving the care of these patients. We must educate, we must train the educated attendants of these patients, because they need a very regular treatment. They need a low threshold for the different complications. Suppose if a cirrhotic patient has started forgetting something, or if the patient's cirrhotic patient is forgetting to say the prayers, or forget the names, or sometimes there are long pauses in the discussion, in the talking, it may be occult HE. If the patient has felt that the tummy is increasing, the patient may be thinking it is because of the case or something like that, and it may be ascites. If the patient has got black stools, melena, the patient has got some sorts of blood, and the patient may say it may be badhazmi, I think this should not be the way. We should properly educate them that what are the red alarm signs, what are the red flags, when they should consult their doctors earlier than the appointment. And if the appointment has been given to see the doctors after 1 month, 2 months, 3 months, or 6 months, they must be very regular in keeping their appointments, because it's only this way that we can prevent the decompensation and we can ensure the proper management of these patients. But on this, I finish this discussion. We shall meet in some another discussion in the future. Thank you. Khuda Hafiz.